Okay, ladies and gentlemen, and a very warm welcome to this session. May I request everyone to stay off the video and put off your audio also. I will ask when I want to look at it because we have many participants. It will take the bandwidth. So just your video off, please. Keep your video off. Keep your video off, please. Yeah, thank you so much. So friends, Cygnia Healthcare, and I'm the founder CEO of the company, and I am committed to patient safety. And all these three webinars that we do, we are doing it because we are in the pursuit of patient safety. Sure, all of us in healthcare know how important is patient safety, and that's what we are there for, to ensure that we do not give more harm to our patients. And thank you. So we have had 2 sessions on 13 on different topics. And if you have not seen them, you can find them on the YouTube channel. And today here you are here with that is me, Tankam Gomez, to review our international patient safety goals. It is not very easy to cover it in 1.5 or 2 time, but I will try to go through all the relevant practical points around those topics. But yes, definitely ensuring what are the evidences around them as well. So keep your video off, and while I'm discussing on patient safety, any questions? So someone told me can't hear. Can you hear me now? Can you give me thumbs up if you can hear me?
Ma'am, very soft.
My voice is very soft, is it? All of you are having same problem or only some of you? Hello?
Ma'am, we can hear you loud and clear. Juliet here.
Okay, maybe it is auditorium in case the sound system is not good. You may hear it, so you may have to fix it yourself, okay? Thank you. So I just take a few minutes to introduce my new partner, nursing. With me, I request everyone to keep your mic off, please. Thank you very much for that. So I have Lissy, please. If someone is not listening to me, I may have to remove them with all of them. You have to so very simple basic etiquette in the Zoom, please. You need to mute everyone and unmute myself. Okay, that's it. I've muted everyone. All right. So now we are going to talk more by chat and hands up and down, etc., because you will not be able to. Thank you very much, everyone. So I would like to introduce Nursing Community Platform, where you have whatever you need for nurses, like find your job outside. You can find other opportunities. I'm trying to create one place where you can have access to job applications. It will help you to build your resume as well, and then you can also write blogs for the leave your concerns, your points, what you in the profession. So it's just getting launched, and these are the 3 ladies behind that. I'm very happy to be partnered with Indrani and Preetha. Indrani is with the HR background and Preetha is with the technology background. I'm a subject matter expert for nursing, and this had been one of my dreams. So when they approached me, I said, we need something like this for the entire community. So there will be employees there who can find you, employers in India and outside. So thank you, everyone. You can visit www.nurseindia.org. You can become, may I make a humble request again? Please look at your screen, keep yourself muted, because once I get into the content, it will be little bit. And I'm very sure that multiple system are sitting nearby. So please unmute. Is not only your sound, there will be echoing sound. So we have almost 3 people here. Thank you so much for such overwhelming response. So let me back to the presentation. Once. Aishwarya, please unmute yourself. If you are really serious about learning this, please respect and mute yourself. If you are kind here because somebody asked you to join and just logging in, you can rather spend this time for something else. Let's not, disturb the class. Nancy, please look after your baby. Okay, friends. So we let's jump straight into the topic. Florence Nightingale told, it may seem like a strange principle, but the first and foremost requirement in a hospital is that we do sick. And that is why we are here as the International Patient Safety Goals. I called it Made It Easy is because I'm to explain this in a very simple manner. Student or a nurse or a leader, everybody can understand that we can do to ensure. I'm very sure have been trained and trained on the goals. But being a nurse with over 40 years of experience, being an administrator, I totally understand that my challenge, that I have these, I was supposed to run a poll, just run that poll. So if those who have access to your mobile, not in the auditorium, you can quickly answer this question. How many IPSGs are there? Can you just give the answer so that we get what is that most people are talking about? So there are 3 questions there. You can answer all of them. So I'll take about a minute, another half minute to go.
మ్యూట్ అయితే రావట్లేదు కదా.
Okay, we will end the poll and we will see what is the. Okay, I hope you are able to see the answers on the screen also. How many I have people who answered 4, 5, 6, 7, all of. Does India release any patient safety goals? 21 people answered yes. I would like to hear from them. When did India release patient safety goals? IPSG, which is most difficult to achieve. So I think IPSG 3 seems to be having the top order. The rest, all of them seems to be having think 38%. Okay. Right. So I'm going to stop sharing the result and let's get on with that. So to answer, yes, India releases, at least I am not aware of India release patient safety goals. We actually borrow them from US, which releases international patient safety goals by JCI International. And in US, they also release national patient safety goals, which are very similar to the international patient safety goals. And we have using them for the last so many years. And I added one seventh international patient safety goals, though not published in the 2023 list that reduced the harm associated with alarm system, but you will find this mentioned in NABH as well. So it also use the similar patient safety goals. Now, why are these patient safety? Safety has to be there everywhere. But these are evidence-based domains which has got very high level of harm to the patient. That is been detailed as patient safety. I think the organizations are supposed to have policies and procedures in place to ensure that the patient is protected from any harm on this domain. So goal number 1 is identify patient correctly. See that this is one domain that has lowest response. They said we don't have much problem. But ask me, this is the root cause of many problems. They are interlinked with other goals as well. Whether it is medication safety, whether it is surgical safety, identifying patients correctly is part and parcel of many things that we do in our hospital. So every single day, nurses are interacting with patients and they're doing many things to the patient, for the patient. So let's try to quickly understand what is this goal number 1 and how can we ensure that we are safe. We have to have 2 identifiers, but it should not be the location of the patient or the diagnosis. Very quickly in the chat box, can you tell what is the most accepted 2 identifiers in India? Not abroad. I'm talking about 2 identifiers in India. Can you just put it in the chat box, please? Okay. Interestingly, some strange answers are coming. Okay. Most of the answers are correct. Patient's full name and UHID. UHID is the unique number patient will get, whether you call it MRN, whether you call it patient record number, whatever you call it. But in the beginning, someone also told, I think someone wrote mole. Mole means some identification mark. Definitely not that. And in the beginning, someone told something else. I'm trying to figure out band. Well, band. This is one common answer. It's a misnomer when someone says ID band is the identifier. Sorry, ID band is not the identifier. The information on the ID band is one identifier. So let's see that how do you identify a patient? Okay. One is that you need to identify the patient when the patient comes to the hospital first time. How do you know that let me only talk from the nursing perspective. You are getting a new admission. Patient comes with the admission sheet or a face sheet, whatever you call it. You are receiving for admission. How do you know that this paper belongs, let's say the patient is Tankam. How will you know that this paper is Tankam's paper? May not be some other Tankam. There is another Tankam getting admitted at the same time. Maybe Tankam Gomez. Both are Tankam Gomez. How this paper that I came with is the right paper? So that is one junction in which you need to identify the patient correctly before you put the ID band to the patient. So I would like you to imagine this in your head as I am explaining this. This is not theory, just see how it is happening. So Tankam has come for admission. The nurse will say, okay, good afternoon, ma'am, welcome. You are here, thank you. And we would like to identify you completely. What is the best way to do? If I can read, give the face sheet to me and say, can you please read this, your admission paper and verify that these are all the details. So I will look at my name, my mobile, my address, and yeah, this is me. Now the band is put on my wrist and I am being advised. I'll say, ma'am, this ID band is here with your name and your UHID, unique number, and we will be using this to verify your credentials. We give you medication, do any procedures or anything. I smile and say, hi, it's me. I can always say it's me. Then if I have any doubt, I should be able to tell the patient to ensure that whatever is being written in your file, you are getting right treatment and right medication, because there is possibility of a name somewhere else in the hospital. So we don't want to take any risk. So we have to match your full name, your UHID number with you, and also match the information on the ID band with the patient file. Understand this as a picture. If we are not doing this, then we are just doing some lip service. That is we are doing. So you have name and UHD number that you need to verify, and how you verify is very important. How you verify? First, you ask the patient, if the patient is conscious, ma'am, can you please state your name? So I will have to say, my name is Thankam Gomez. Now one nurse will say, oh, I yesterday only asked this question. How can I ask this question again? For safety purpose, you will always ask the question. Ma'am, may please state your full name. Don't say, hello, ma'am, Thankam. I may not be even paying attention. What are you calling me? I'm in the hospital. I have no idea what all dangers are in the hospital. It is better to ask the patient to state the full name, provide the name, ask the full name, keep watching what is in your file. And then you say, let me just confirm your name and number with the band and the file. It is the comparison. It is not the ID band that is the identifier. The information on the ID band is being matched with that of the patient file. I hope all of you got that. Very basic thing that needs to be done. When all you need to identify the patient, to say hello, you don't need to identify the patient. This is before medications, blood transfusion, sample collections, all kinds of procedures, transfers. Sorry. Okay. Transfers, handover. Wherever you are handing over, so include the patient, match the information. And there is a very clear-cut to have very sacrosanct process of identifying the newborns. So hospitals are expected to have policies and protocols written down, and then they are followed up, and they need to be monitored and measured. The process is being followed completely. I will tell you that in my own experience, when I used to go for rounds, I always had this habit of doing hand hygiene in the patient's ID band. So once when I went for round, I saw that one patient's ID band was there, but all the details had been just completely. So I asked the patient, what happened? I can't see anything. So he said, oh, this has been like this for the last 2 days. So what does it mean? Last 2 days, nobody had identified the patient as per the protocol written down. If I did not see that ID band, when somebody asks me as a nursing head, I will say, yeah, in our hospital, everything is very perfectly. But that day I realized it's not happening. Immediately, I called my educator and clinical instructors. I said, let's do a prevalence audit immediately. I said, all you have to do is check all the patients. One, whether they have an ID. And if they have an ID band, whether the information on the ID band is correct or not. And you will not believe me. It was such an eye-opener for me that I should not trust that it's happening hunky-dory just because I have got a protocol written down and I have nurses. It does not, you must believe this. So it's very important to check that protocols are written down. You have an ABH accreditation, you have JC accreditation. We cannot live in this fool's paradise thinking is happening correctly. So it's very important that all these goals that we are seeing, someone needs to pay attention, audit those domains every now and then. So we had to continuously audit this. So from there, we had two checklists: how to identify the when patient gets admitted, and what all things to be done when you are identifying medication. So we had prevalence audit for all of them for a few months. Then we stopped. Then we used to have on and off prevalence audit just to check that things are happening the right. Identification of newborns, whatever all mother's name, mother's UHID, one document passport having two ID bands on the same baby to make sure both the ID bands will have same information which is matching with. Now I have added the last one. This is, I just happened to create this acronym when I was doing one of the sessions. I call it as SASA, like LASA. This is again a problematic area. What is SASA? Sound alike and spell alike patient. Sound alike, spell alike patient. That means names which are sounding similar or their spellings are. So this is very important that in your system, in the protocol, whether it is the electronic or it's a paper-based system, you are having a way of alerting the people that this is a SASA patient, just like the LASA patient. This is I have never done before when I was the administrator in Fortis. But today, if I have to get into hospital and start doing things all over again, I will do a lot of things new because our knowledge of how things work and how we used to, everything is changing very quickly. So it is very important that we should also reinvent ourselves and find innovative ways of ensuring that we build redundancies in the system. Redundancies means, checks and balances so that our nurses are protected from making a mistake by. So my request to all the nurses is that never do shortcuts when it comes to identifying patient. Don't say, I have been looking after this patient for the last 5 days, so I know this patient very well. It doesn't work. We can be distracted. We can be thinking something else when we are doing something. That's how we do mistake. Nobody comes to hospital by saying that today I'm going to make. None of us want to do that. But yet mistakes do happen. And why do we do these sessions? To make sure all the nurses, all the nursing students, all the administrators understand our rules very clearly. Nursing administrators, my request is only to say, do not create a sense of security all the time that everything is happening correctly. So I always used to team members, I love to trust all of you, but I don't trust anyone. It only means that I will be checking all processes every now and then. It is very important to ensure safety of our patients. So when you are giving handover, shift handover, when you are transferring patients between wards to ICUs to OT or to the MRI or to the CT scan, whenever you are handing over another person or another department, follow the same protocol of identifying the patient. You have the right patient, you have the right file, medical records, you have the right procedure being done to that patient. So this cannot be emphasized. When I saw 15% is my problem, I just thought, is it because 15%? Because you're not doing prevalence audit on this? I don't know. I leave it to you. I really hope that today you have told yourself that I'm not going to do a shortcut around this. It is not worth it, my friends, because there are so many mistakes that happen because wrong patient, wrong treatment, wrong patient, wrong surgery, wrong patient, wrong medication. I am very sure you are aware of the danger which is just waiting there to happen, waiting for one nurse to be little distracted so that the mistake can happen. Second one is improving effective communication. Now, you all must know that communication is always the top 3 reasons for sentinel events. Imagine, I am now really sorry. I can only admit 500 people and now I cannot admit anymore. So in case you belong to the same hospital please share your screen with someone else, because I have maximum limit of 500 we have reached there. Thank you so much. And I request others to tell your friends to join in the classroom or join with you to watch this. Otherwise, I'm sorry, you can watch the recording later. So improving effective communication. As I told you, it is one of the top 3 reasons for sentinel events. So you can imagine the importance of communication. So what does the document say? So I was referring to the NPSG, National Patient Safety Goals, and JCI, NPSG, the document wherein they say what all thing needs to be done for this. So 2023 document, the communication is focusing more on managing critical results. So that's why I'm that here, but then I will talk about our own problems also in a while. So they are talking about having a written procedure for managing critical results. So definition of critical results, test results should be documented in the organization. So you need to understand, do we have a critical test results? The protocol should say who will inform whom. So if lab has got a critical result, whom should they inform? They should call the ward and give to any nurse, or they should ask for the nurse in charge, or only it will go to the doctor. Now it is to be designed by the organization. So it must be given to someone who is responsible enough. That's very important. You cannot give to any staff nurse. It doesn't work. I am looking after patient A, some patient B's report is being given to me. It's not my patient. I may take the report, but since it is not mine, there is a possibility that I may miss informing the right person. So should it be only the shift in charge or the ward in charge? That who should be receiving this, or the doctor who is on duty? It all depends on how your organization is set up. Now, acceptable duration for reporting results. So you have I can imagine a list of all the critical test results, like you have to inform serum potassium that is out, maybe the electrolytes when they are out, they should inform. If they are less than this, more than this, less than 2.5, they should inform, more than 5, they should inform. Something like that, there will be a list which says that they need to be informed, to whom and how soon it should be informed. So lab is also accountable for informing the critical results to the right within that acceptable duration. So that should be part of the protocol. Now, all this protocol should be known to the people who are actually in the protocol. Writing is okay, but somebody needs to live the protocol. So that is also important. Yeah. So once that is written, everyone should be, trained for that. Now, implementing the procedures is, so I have put 2 words there, read and ISPA. Now, these are not found in the documents that I was referring to. It's not written down. Many hospitals do this in place, but I have been in training from 2013 continuously, thousands of nurses. Till today, I don't see a perfect readback, and I can see a better ISBA. You all must have heard SBAR. But perfect readback, I am yet to see. So I'm going to explain to all of you that what is the expectation of readback. Readback means you are going to read from somewhere. It is not repeat back, right? So when a doctor calls you to give you a treatment order, or the lab is calling you for critical test results. So what is the component of readback? I do have an audit checklist, which I tend to tell my, people who come for training to do the audit to confirm whether it is really happening the way it is. How is it? I'm going to do a very quick demo to you. So call comes, tring, tring from the lab. I pick up the phone and I'll say, okay, good afternoon. Tankam here, SICU may help you. So from that side, they will say, hello, this is Shamir. I want to inform you about this bed number 2. Am I going to take the result as bed number 2? I will say, hold on. Can you please tell me the patient's name and UHID number? While the person is getting the UHID and I will get that patient's file. But number two, practically, I can find the file. I'll say, okay, please tell me the patient's UHID and number. So they will tell the UHID and the name, and I will match in my file. Okay, I've got the right patient. Then they will say, okay, I just want to inform the serum potassium of this patient is 2 So I will say, just hold on, let me write it down. So mostly in hospitals, there is a place where you can write the critical test result. Where is your protocol? You find the place, and I will write down the date and time, and I will write down that, this is the serum potassium is more. And I'll say, may I know who's speaking? Shamir. I'll say result given by Shamir Lab. And then I'll say, okay, Shamir, let me read it back to you. And I'll say, okay, give me the patient name. Okay, Mr. Dhanraj, and UHID 64786, and potassium is 2. Is that right? And the other person will say, yes, this is right. This is called feedback. You have to read back from a file. You cannot write in chits of paper. It is not safe. So you should have in your hospital designated place you will write the critical test results, or where you receive telephonic orders from the doctor. There is nothing called verbal order. Please understand. Verbal orders are only reserved for emergencies like code blue or somebody crashing. You cannot take a doctor standing in front of you and take a verbal order in writing. You are not going to take that. You are not supposed to take that. Doctor is standing in front of you, he might as well write it. Code blue, there is no time, so there is verbal orders being done. There you practice a safety procedure called repeat back or check back or call up. That's a different communication tools. Here, receiving test results of lab or MRI or anything, it is read back. You need to write it somewhere and you are reading back. It's a communication tool. Now coming back to ISBART, it started as SABR, situation background assessment, recommendation or request. This is a tool that you use when you are communicating with the doctor for any problem. I like to reduce this ISBART as a clinical communication tool between caregivers, nurses and nurses and nurses. And I personally do not advocate shift handover. Recently, I've come across the tool called IPAS, and I have also developed a tool called AISSACT. So we need to come up with some tools which are going to work for us. SBAR I tried when I was in the Fortis, but it didn't work because it's nice to say we have a tool, but my root cause for many problems were related to communication gap during shift handover. So I realized it's not helping. So SBART or ISBA, I would say that train the nurses to inform clinical situations to doctors or anybody else. I stands for identification of the patient and identification of the person whom you are talking to, identifying yourself. 3 identifications very quickly on the phone call. Introduce yourself. Then talk what is the situation, the background, what's the assessment of the patient. What do you want? You want the patient, doctor to come and see the patient, or you want the doctor to advise you or something. The T is put there, courtesy, thank you. We added the I and the T both sides because these are not granted in our situation. Our nurses do this completely all the time. Many of them could be doing, but read back confidently, I can say, is one of the non-correct communication tool that I have seen, because in almost all my trainings, I get people to demonstrate this to me, and I don't get this completely correct all the time. So the very important, after all the protocol, after the readback is part you have trained, make sure that everyone trained, everyone concerned is trained. Not only just, I wish, I could have a smaller session where I can ask people to do the role play, people can understand. I will tell you some easy way of check. Today's date, technology is fantastic. So it is to use technology. Get your team to video record these protocols and procedures. Then put them up during your training sessions. Ask the other team members to look at it and say that whether it's going well or whether it is not going well. It is based on It should not take much time. And also use your checklist to check whether all the parameters are being adhered to. Or I'm giving multiple ways of addressing the issue. I'm not actually doing a teaching of that domain. I'm giving you tips as to how to stay safe. Now, to all the nurses, the new nurses, the students, it is your responsibility to understand what is the protocol in that hospital. Understand what does it mean. Please don't rely on somebody told you. Use your intelligence also, common sense also. If I am saying read back, why should I be only telling? Read back is an English word. That means I should be reading back from somewhere. Where should I read back? The place where I have read. And that place has to be patient file. It cannot be because it can get lost. You will have to write the UHID, write the patient name all over again. This is how it started many years. Today, we should understand most safest way to carry out these domains. Very important. Now, the next area where problems can happen is handover. Shift to shift, department, change of caregiver. I'm looking after the patient 2 hours. After 2 hours, there is another nurse who is coming to look after my patient. I have to give. Now, how do I give a complete? I would like you to look at the tools IPASS. I have seen the earlier one used to be IPASS the baton, which I thought was too long to follow. But now recently they have something called IPASS. So I would encourage you to look at it. And if someone is interested to look at the tool, India made tool that I have created, please message me. I would like to share with you to see that whether it is working. At the end of the day, what do we mean? What do we need? That our nurses give handover completely without missing anything, right? That's what we need. And you also need something that is easy for you to remember. Now, very quickly for you to kind of remember the tool that I was talking about. I'm just going to look at my pen. Seems to be missing. I wanted to, I'm so sorry. Chronic pens that I wanted to write. So the tool that I am talking about, let me find where is, yeah. One is IPASS. This one that what I had created is called, okay. This is acknowledge, introduce and identify, say, show, ask, conclude, thank you. This is a tool I'm urging if someone wants to try this out along with me, we can create evidence-based practice around it if required. Because we need to develop our own practices which can work for our nurses and our students in our hospital. I am requesting those who want to use, you can. IPASS is a validated tool. That is something you can look for. So nurses and students, please remember, in handover, you are telling the next person, all this I have done, all this you need to do. So we need to be very diligent to make sure that I have given over everything. It's not very smart for a nurse to say, oh, that nurse did not tell me. So I will tell you, when I was assigned nurse, I had this habit of standing with the nurse. This ISEC tool is created from my own experience. Both the nurses introducing themselves to the patient and then saying what we need to say using the file. From page 1 till end, we will be saying that today this was written, this is given, this is given, this is the intake output, everything I'm showing and I'm telling the nurse. And then finally I ask, do you have any questions? And I'm showing all the IV cannula, the catheter, everything I'm showing, the skin, everything we show. Then we say that, do you have any questions? This is very, very important to take that time, not be seen as a time for nurses to run away. Sometimes nurses will say, Idi, you have come. I have written everything in the file. I have to go somewhere. Please read. There is something, just give me a call. I will run. And that is not acceptable, my dear friends. You're taking a big risk around patient safety. Maybe something will not be done completely as expected. Patient can be harmed. Next day, when something has gone wrong, your leaders, you're in charge, your nursing head is spending half a day trying to figure out why and how this mistake happened. That time they should be using something more beneficial than just putting out fires. It doesn't work. Right? So always follow the right protocol. That's all I can tell at this moment. Protocols are available in your hospital. Understand them, follow them, try not to find shortcuts. So coming to goal 3, I'm also looking at the time because there is one segment where I will in a little extra time. That is the medications. Let me, every single goal is very important. Okay. So goal number 3. In India, it is today standing as improve the safety of high alert medication. When you look at the 2023 National Patient Safety Goals document, it has been now written as the safety of medication, not just high alert, generally about the medication. So let's focus on this particular domain called high alert medication. So what is required to be done in a hospital? First of all, there has to be policy which will standardize everything around the high alert medication, how it should be ordered, how it should be stored, how it should be prepared, how it will be administered. Everything needs to be written down in the protocol, documented, and there should be a list of HAMs. That is high alert medications. They're all available in the internet. The list should be available and nurses who are handling medication should know about this list. Improving access to information about these drugs. That means there should be reckoners. Somewhere the nurses can go and read about this medication if required, whether it is in the electronic form, whether it is hard copy form, somewhere it should be available for nurses to find out what is this medication, what can be done. Now I would left this word here, privileging nurses. This is a call out to all the senior nurse leaders and also for nurses and nursing students to know this is not something that we can give to our nurses just because they have got a license. This is something that I have learned. It cannot be given because medication is a very dangerous area that we are managing. And when it comes to high alert medication, it's even more dangerous because their therapeutic range is so narrow that in case you make a mistake, there is no stepping back. I had to give a particular dose of crocin. I gave double the dose. Nothing may happen. But you do the same with your high alert medication, it can make a difference to that patient's life. So I always believe that you should privilege your nurses after ensuring that they are having the right knowledge. They know the calculations, medication calculation, IV infusion calculations. They know the domain well before you allow them to give medication. Medication is not just about giving medication. All forms of medication the nurses are allowed to give. So there should be a process by which you can privilege the nurses. And in the same protocol, one should say that when will you withdraw these privileges? In case you find the nurses are not safe in doing this particular procedure, we should be able to withdraw the privilege till the time they can prove that they are competent. These are not things that are granted. It is not. It should not be so. So it is very important that, ensuring they are trained and then they are privileged and then they are given the privileging to do the medication administration. Limit the access to high alert medication. Where do you keep these high alert medications? Do I need to keep it everywhere? Or can I reduce the number of sites where I am keeping the medication? These are, administrative controls that you can think of. And then using auxiliary labels and automated alerts. Important. How do nurses and other caregivers identify these as, high alert medications or, high risk medication? So these are things that one needs to keep in mind while you are drawing this particular protocol. Then adding redundancies, that means some checks and balances. Who can prescribe pilot medications? Who will do the drug oversight? And who will be double checking at what time? Now, I want to stop here for a moment and advise all nurses, please do not do the shortcut of double checking your high alert medication. Let me tell you a real story. I was the nursing head in one of the hospitals. So I get a call, this patient's son is shouting in the corridor. So, ma'am, can you please come? When there is such, they come. So I go. When I go there, what do I find? This son is, of course, well educated. He's literally shouting at the top of his voice that if I was not there, my mother would have been dead by now. I request him, he said, let's go inside, let's talk. So I know what has happened. The nurse changed the syringe, insulin or heparin, one of the drug, I don't remember very much. Do you remember? It is supposed to go 3 ml per hour, 3.0 ml per hour. The nurse put 30 ml per hour. So I'm very sure if I could see all your face, I can see, oh my God, that's not good enough. Question is, how did this happen? The root cause was, when I talked to the nurse, what we found out, she was busy. Whatever she was doing, she was too busy. Every time that is the answer, no, ma'am, so sorry, I was busy. But you can't kill a patient for that, can we? We cannot. So that is why we protocols to make sure that you people are safe. I always tell my nurses, the protocols are not written because the hospital is going to MBH or JCI, or we only want to protect the patient. We also want to protect you, my dear nurses. That's why the SOPs are written down. Follow the safe practices. This is very important to appreciate that protocols are not there to punish you. It is there to protect you. So what happened here? The nurse herself, she was busy. And when she prepared the syringe, she asked the senior, Didi, मैं शुरू करने जा रही हूँ. Didi said, I'm busy, कर लो, बाद में देख लेंगे. Sign कर दूंगी. Typical dialogue. But then nurse went in a hurry. Instead of putting 3 ml, by mistake, it was 30 ml. The son was sitting there. He was well educated. He immediately he stopped the machine, and then he was shouting at the top of his voice. Why wouldn't he shout, my friends? If it's our mother, my father, am I going to say, oh, by mistake it happened? I caught it. I am not going to be kind. None of us is going to be kind. So it is very important that, you follow. It's very important that double checking should happen at the bedside. Compare the order with the medication that is prepared with the patient. The person who is checking, the senior, should make sure it is the right patient, the right medicine, right dose, the right road, all the rights should be checked. Then on the counter side, we should not become that, I see 2 signs and everything happening safely. It does not happen. We should not become, signature and tech kind of care people. Maybe nothing will happen for days together, months together, but one day something serious, there is nothing you can do about that. Correct? You cannot stop the harm. You cannot retrieve the harm. So it is always worthwhile to follow the right protocol. Now, to all the senior administrators sitting there, this one event led to us thinking what can be done so that this should not happen even by mistake. So there was an engineering solution that we found. We talked to the doctors. In the wards, we were giving insulin, heparin through the syringe pump. Most of the drugs were heparin, insulin. We talked to the doctors. We asked them, what could be the highest level of infusion that we can allow? And we asked the biomedical engineer, can we lock this syringe pumps? So if I remember correctly, we locked it at 8. That means even if somebody wants to increase more than 8, we cannot increase. These are called engineering controls, which are very, very effective. I'm sharing this all because I'm sure that there are senior nurses. Now, young nurses who are tomorrow's leaders. It is not about just fixing the person, training them again and again what they know, but trying to understand the circumstances and trying to see whether I can do something above the person. That is going to be far more easier. Now, let's say if you have high alert medication, you have LASA medication, you have SAS patient. So the moment you click on that drug, that patient, there should be a red flag, no, which says double check, double check, double check. So it's like a reminder to someone. This is almost like when I'm driving, I cannot remember that when the crossroads come, I should stop. If the light was not there, everybody will drive through and there will be far more accidents. So the government has put engineering control. They put stoplights, green, red, green, yellow, and green. They said, stop, don't cross now. So if we don't follow the protocol, I'm taking a risk to having an accident. So similarly, we need to find tendencies in the electronic system or in the process. So double check is a manual process. It's a human process that you should double check. Nobody can come and check that double checking again. It doesn't work, right? So it's very important that we also carry a high level of integrity. Integrity is very important in patient safety. It means doing the right things when nobody is watching. 98% of what we do is not supervised. It is me and my patient, correct? Nobody else is knowing what I am doing. So isn't it important that this nurse Tankam should exhibit the highest level of integrity? We don't have a survey in India, but in US, whenever there is a survey, that profession which carries the highest trust in the public eye, except for 1 year, it is always nursing. Why is it so? There is something that the public is trusting us to do the right. All the mistakes can happen, but when it happens because you did not follow a set process or a protocol, that is sad. And that's not smart also, because when you get into trouble, really get into trouble. You can't get away saying I was busy, I was this, and you will be called multiple times to explain how did it happen. You don't like it. Nobody wants to do these things to anyone. Everybody wants to do their job, move forward. But if every single nurse decides to exhibit the highest level of integrity, the problems will come down. So all these sessions are being done to literally talk to your heart, not to anybody else, to your heart. You have. Now the question is that what are you doing about the knowledge that you have? Are you trying to implement it, follow it all the time? My question to all of you. So this is what is recommended in the document. All this should be done. Okay. So I'm continuing with the goal number 3. This is the 22 high alert medications list. I saw a fantastic document on the internet from government of Malaysia, where they have a complete SOP on how to manage high alert medication. And this list is from that particular document, 22 medications. Okay. So I don't have time to go through all of it. But then you should know that when I'm managing this medication, I am taking a risk. I have heard of patients who got muscle relaxant, had respiratory arrest. We cannot tell the family, sorry, we made this, the patient is gone. Was supposed to go home, but gone because someone just gave by mistake pancuronium or atracurium or vercuronium. Doesn't work, right? Some of these medications may have antidotes. Many of them may not even have any antidote. So one need to be extremely careful, giving your vincristine intrathecal is a well-documented error. And this has happened in the hands of doctors. So there has been a lot of work around high alert medications, but there is a top 5 list also. The top 5 list, most commonly used. This list is from JCI. They talk about the top 5, which is very commonly used in our hospitals. They are the insulins, the opiates, and the narcotics, injectable potassium chloride or phosphate concentrate, intravenous anticoagulants, and sodium chloride above 0.9%. And there are 22 total list. So really, we need to know. So when I was in Fortis, we try to identify the high alert medications in each unit and have a separate list for that unit, because no point in teaching the nurses to know about all 20 high alert medication if they are not in that ward, if they are not using any of them. It doesn't make sense. Better to have them know the high alert medications which is being used in their particular unit. And the same guideline goes for what are the LASA medications, which that list has to come from pharmacy. These are the LASA, and there has to be some periodicity. Now, those who don't know what is LASA, this is look alike and sound alike medications. So we are continuing with the safety of high alert medications, goal number 3. You can find this. This is from ISMP, Institute of Safe Medication Practices. There's enough documents available to go and look at it and see that what is that I need to do to educate my nurses. Nurses directly can go and educate themselves. Everything is available. Now the question is, do I spend some time reading about these things? I've been doing IPSGs for years, but when I committed myself to speak today, I again went and read what is the current situation. What is it that the current document is talking about? Okay. So I found these things. Now, this is a very interesting, common risk factors, which I really wanted to share with all of you. This is from that Malaysia document that I was referring to. Very nicely summarized. Common risk factors with high alert medication. Different route of administration. That confusion between routes, whether it is IM, IV, intrathecal, or epidural. This can lead to medication errors with high alert medications. The second one is incorrect preparation. That means it was not diluted properly, the wrong diluent was used, or incorrect dose, incorrect calculation. So these are all hidden dangers which are sitting there. So let me, sorry about that. When I use the pen, sometimes, okay, let's come back to that. So incorrect preparation of drug, misinterpretation of medication order. So that's where you have a do not use abbreviation list. All of you have this. I'm not waiting to ask whether you have it or not. If you have it, great. If you don't have it, make sure have it or ask for it. Students and new nurses, you should ask for it. Do not use abbreviation list. Where is the LASA list? Where is the high alert medication HAM list? High alert medication list. Where are they? So that you can educate yourself. Wrong infusion rate. That means you have calculated the infusion wrong. So there is a medication error that is happening. Alike, sound alike medication. I'm sure that many of you are aware. Similar packaging, similar sounding. So they need to be managed in a different manner. And availability of product variation. This is also another common problem in India because so many trade names. Same medication, so many trade. Though government is advocating for generic, drug prescription, I think we are miles away from that. Then ambiguous labeling. That means you cannot read the label. Now, if nurses find, the nurses who are working at the bedside, if you find that your label can be hardly read, which nursing group will escalate to the manufacturer to say, we cannot read this, we cannot use this because we can't use this. We cannot read what is the concentration of medication in this particular vial or ampule. It is very important that we as nurses, we need to assert, say that we have a problem. We need the manufacturers. You should not think, oh, what will they do? We are talking. If all the nurses are going to make hangama, say that we cannot read it. nurses who are 40 plus, can they read? I cannot read the small labels. I have a magnifying glass with me to read those smaller ones. And I always keep thinking every time, oh my God, maybe young nurses also might be having problem. I don't know, because no one came and told me. It's not readable. So think about all these things, friends. Maybe it is time that we really have to take some things into our hands and talk about it. This is very important. So here are some samples of, high alert medications labels. One second. So that you can see all these images well. So you can see that how, this is called the Tallman lettering. If you see here, adrenaline, there is capitals and then there is, smaller one. This is small case. It is Tallman lettering. That means this is a LASA, right? So you can have high alert stickers, high alert medications on the ampules, on the vials, on the side, somewhere which is alerting the user that be careful, double check. This is not a simple medication. You are going to handle a high alert medication or a LASA medication, because LASA, high alert, no high alert, it doesn't matter. You will make a medication. They look same and they kind of sound alike. So the processes will start from the pharmacy, the area of preparation to the administration. So one need to know, if you see these things that this is not being done in your hospital, ask for it. Because if this is not being done, you're already taking a very big risk of medication, which you will not be able to help the patient also in many instances. Now, I found this as a good checklist where you could ask, sorry about that. This is a good checklist to ask assessment questions. So I'm going to read through it. Which medication has been reported with serious errors in your facility? There has to be summarization. I am very sure your quality or your safety champion or quality nurse will be doing this. Which are the medications which are commonly associated with error in your organization? Does this medication treat high-risk patient? Are they used in neonatal critical care elderly? Question to ask. Are there multiple formulations? This is high risk, but there are multiple variants. Do I need to tell the management, no, I don't want multiple. Should there be limited concentration available? Multiple types of concentration. Do I need multiple types of concentration? Does the medication match the indication you need? Do you have those there? Should there be maximum dose limits when you make the protocols? Should there be? So I'll tell you another story. In one of the hospitals that I work, I happened to find out that in medical ICU, my nurses were giving neat potassium. You know, neat potassium? Undiluted potassium loaded on the syringe pump and being given. I almost lost my breath when I heard that. I said, after everything, we got accreditation also. This is something that's happening. So when we try to look at what happened, the doctor just simply wrote in the file, KCl 4 milliequivalent per hour. So nurse loaded the KCl into syringe pump and she adjusted the dose to give 4 milliequivalent per hour. So then finally, what we realized was that we did not have very strict protocol about how to prescribe the high alert medication, the recommended dilution. This is all the doctor can write. He cannot vary it. You cannot give a neat potassium just because the doctor wrote. It is not allowed. So we actually had to go back and create new policy stating for all these, problems that we were having, potassium, magnesium, calcium, for all that concentrated, 25% dextrose. So all that we went to pharmacy and therapeutic committee. We created that protocol to educate all the doctors as well as nurses. After that, my department used to audit to ensure that the prescriptions and the preparation administration is going safely. So there are multi-modal approach to ensure that our processes are safe and our processes are following the safe protocol. Are weight-based dose considered? Is the route for administration considered high risk? Should there be a limit of maximum infusion rates? This is what I told you we had to look at. Is an independent counter check recommended? Yes, it is recommended. Does the medication require credentialed personnel for administration? As I told you, privileging. You need to privilege nurses who can handle all these medications, which is sitting with so much of risk for our patients, you know. So you need to look at that. Special monitoring required are auxiliary warning labels. These are questions to ask ourselves, you know, do we do this? Most of the answers are already with you because most of the hospitals who are participating here, you have some form of accreditation. So these are all part and parcel of your accreditation process. So I hope it is all in place. So now these are some your LASA medications. This is called Tallman lettering. So you can see label is like this: ephedrine, epinephrine. They are very different drugs, right? When you put the Tallman lettering, this is some. Can you see that? So this also need to be standardized. How will high LASA medications be actually written down? It has to be approved. It cannot be that my educator, they want to speak like this, so it will be written like that. No, it should be documented somewhere. The labels will be only created like this. This is very, very important. So when you identify your LASA medications, they should be written down how they are going to be used for labeling purposes. You can see another one, phenylephrine, dobutamine, and dopamine, how the Tallman lettering is being used for labels as well. I hope if you are not aware of these things, make a note of it, go back to your hospital, ask, where is it? What does it mean? Maybe you are using this without even realizing that this is a Tallman lettering. Must with you, ऐसे लिखता है. So find out what are LASA medications. Are they all with Tallman lettering or not? Even the labels that are created for that should be in this particular format. So we talked a little more about high alert medications. We continue to do that. I want to just bring your attention. National Patient Safety Goals 2023 in US also talks about this, improve the safety of using medications. They're not talking only about high alert medication. They are generally talking about all medication, but this is what they have written in that document. Label all medications. So now this focus, now they have already taken care of LASA high alert. Now they are coming into a new problematic area where they are saying all medications on the anesthesia trolley, wherever, you know, wherever multiple people are managing medications, perioperative, off the field, on the field, every single thing should be in OT and in procedure, like in cath lab, etc., you know, where people are preparing and keeping medications, every single thing, whether it is a syringe or a container or a bottle, everything should be labeled. So, and the second focus is on anticoagulant therapy, warfarin, heparin. This is also one of the focus area from WHO. Then introducing reconciling medication information. Now, many of, you know, corporate hospitals might be having a protocol on reconciling medication. Now, I will make it into a very easy to understand. Reconciling means when the patient comes to the hospital, you ask the patient what all medications you are taking, for what purpose, what is the strength, get it documented. During the hospital stay, you are paying attention to this medication also. Patient was on this medications, we need to continue this, maybe something we will hold, but when the patient goes home, you need to restart something. So you have reconciliation. That reconciliation means making sure that this is speaking to this one. Home medicines, inpatient medicines, discharge medicines, they are all taken care that nothing is forgotten, patient education, patient is going home. So I'll tell you another story to say why reconciliation is important, to ask the questions. And having this chart in front of you is very important. Patient comes for elective surgery. Patient is on beta blocker. Shalini, please keep your camera off. Don't walk around with your camera. So patient is on beta blocker, came for an elective surgery. Doctor told, hold the beta blocker. Patient is not hypertensive and unstable angina. Patient is on beta blocker. Beta blocker stopped for surgery. And after that, everybody forgot to restart the. When did you come to know that the beta blocker was stopped? I think after 48 or 72 hours, the patient developed chest pain with ECG changes. Fortunately, he didn't have a heart attack. That's the time everybody realized the patient's beta blocker was not started. So patient was having beta blocker, withdrawal, and then angina coming back. So you can imagine, because the medication was not reconciled, patient could have suffered a heart attack. So it is very important to know what medication patients is using at home. And I'm sure all JCI and NABH accredited hospitals are already doing this process, but every staff should not make it too complicated, so it is difficult to follow up. It's very easy to put a simple system in place. Years ago, we started this even before anyone started talking about this in India. We created a simple format. We wrote home on one side, and during the stay, we started just writing what medicines are added to the patient. And at the time of discharge, again, the discharge medications are written. So in one page, we're able to see that have we missed anything? And when I was in Fortis, we had specialty nurses. They used to do this so beautifully. It was not even given assigned nurses. We had specialty nurses for each specialty. So they became pretty good in managing this medication reconciliation. And believe me, it added a very good safety net medication. For me, I was having more peaceful days rather than worrying about all these things. So now that is being asked for now. So when you are doing medication reconciliation, you must understand what is the process in your hospital. I wouldn't know that. But the process needs to be simple enough for everyone to follow. That is what is most important. So this is a part of the NPSG in US 2023. I brought it here because definitely when it appears in Euro 2, it actually gets into JCA also. So maybe we should start looking at this special focus on OT and procedure areas, whether those medications are labeled or not. Anesthesia technicians. Now, in the document, sorry about that. So this is a cut from the same document, which is talking about, where the universal protocol, they call it as universal protocol for effective communication between caregivers. So now this is written under goal 4. What is goal 4? Chat box? Goal 4, can someone write me what is goal 4? Goal 4, goal 4. IPSC 4. I'm waiting for someone to answer. We have 450 people. Okay, correct site. Safe surgery. Yes, thank you. Thank you. So this is ensuring safe surgery. So in the current document, they talk about universal protocol. Universal protocol means this needs to be done every time, every hour, for every single patient. Pre-operative or pre-procedure. Now, one thing they are very specifically mentioning that this process needs to be given not only for surgery, but also for invasive procedures. So timeout has to happen even for invasive procedures, like your cath lab or daycare surgery or your any invasive procedures. So you need to figure out that where all you need. So there are three main components: pre-operative, pre-procedure verification, site marking and the timeout procedure should be consistent. So I will tell you a very simple thing. Patient is going for CT guided biopsy, right-sided CT guided biopsy, right side lung. Don't you think that patient will need a site marking? He's not going for surgery, he's going for a procedure. So we need to think very practically, and there is no need to wait for someone to come and put a dun on our head that now NABH will ask for this. Most of the time, we are trying to do things because accreditation asks for it. But if we turn it around and say we are doing it to make sure that our care is safer, then the stress is less. Then our life will not be from accreditation to accreditation. Then the life is always safe all the time, not just before accreditation. I'm just being very, very candid about this. So this also talks about, suppose a patient comes to emergency trauma, the surgeon is there and surgeon is taking the patient to the OT, then they are saying site marking is not required. But I will not even think of writing it down because that will be misinterpreted and then told site marking is not required. So, universal protocol for safe surgeries based on to prevent wrong person, wrong site, wrong procedure. And that must be prevented. It's a never event. It cannot happen. You cannot say sorry to someone after it happened. It cannot. So it has to be multiple complementary strategies. Complementary strategy means not just doing what they ask. Maybe you will do something more to ensure that the correct person, the correct procedure at the correct site at the correct time, right? So I am going to explain something that I think the hospital should be looking at. So first, let me just talk about the document. What does it talk about? Implement pre-procedure process to verify the correct procedure for the correct patient, correct site. The word surgery is now not being used. So please understand the process needs to be implemented not only for surgeries, but also for all basic procedures. This is very important. Identify the items must be available for the procedure. Use a standardized list. So that means what is required for that procedure, documentation, consent, test results, radiology films, blood, implants. What do you need? Someone needs to ensure that everything is available. The site where required, if there are bilateral organs, then site marking should be there. And then conduct timeout immediately before in procedure or making the incision. Now I'll tell you one more story for procedure. It happened in the SICU. The doctor came for round and the doctor told, let's say patient number 1 and 2. Bed number 2, he said, after rounds, I'll come back to put the central line. Bed number 2. Okay. He went for rounds. Meanwhile, for something, I don't know what happened, the bed number 2 had to be moved to bed number 1. And bed number 1 came to bed number 2. Okay. You can imagine, patient just became. So he went straight to bed number 2 and said, "Hi, sister, central line." And this assigned nurse, central line. Oh, okay. He's asking, so I will prepare. So she ran to prepare for the center. We were lucky. The in charge was very smart. She heard this. She told, "I'm sorry, doctor, this is not the patient. The patient is in bed number 1. The problem why it happened, we are not using patient identifier. We are using bed number. And if you tell me that we are not using this anymore in any of our hospital, I will say that's not the truth. We still tend to use that because we are so used to 101 diabetic, sugar kar lena. Bed number 2 ka A line, bed number 5 ka this line. We need to stop it because it may not create any problem for long time, but one day it will create the problem. That day, the wrong patient would have had the central line if my team leader or the in charge was not alert. Yes, so it's very important to understand that how we are identifying the patient. So as I told you, identification of the patient is all over the safety goals. It's not just one goal, not only at the time of admission or giving patients is everywhere. Before procedure, it's already there. So time out. So very quickly, we will talk about that as well. So before we get into the surgical safety checklist, let me just quickly talk about a couple of things that you may be having, but you should use it very smartly. Many hospitals will have a pre-op checklist, which is available in, okay. The WHO safe surgery checklist is usually used in the OT. Let it be there. We'll come to it in a minute. In the floor, you will have a pre-op checklist where you write all the things that you need to do in the ward itself. And then it is all so that nothing is missed, whether clipping is done and whatever it is, there'll be items. So you do all that checking. In that checklist, you must have morning TL, double checking and signing. If it is not there, please include it. But it has to happen in person. When the morning in charge comes, this is one of her first priority to see all the patients going for surgery, using the checklist along with the assigned nurse, check that everything is done properly. All the x-rays are correct, lab results, everything. Sign. Add one more layer. Add one more layer underneath that all these are received by the preoperative nurse. I'm telling you systems that can help you. It is not extra work. Assigned nurse goes to the OT, pre-op nurse is receiving this patient with the extra and everything. Let them sign and take off the patient. No? So there'll be something that is being explained and understood. Now in that, it's very, if you can add one thing, ask the patient to confirm his surgery consent. Whether the patient gave the consent or the patient knows what surgery he's supposed to do. If that one line, it is going to add a layer of safety. That's why I wrote that pre-op checklist there. Now coming to safe surgery checklist, sign in, time out, and sign out. There are incidences where patients were seen as the wrong patient last minute. The ID band itself was wrong. So what does it mean? For days together, everybody is looking after the patient, giving medication, doing everything, without following the right protocol of identifying the patient. So you should always remember, when one mistake happens, it is usually the tip of the iceberg. There is a whole lot of problem hidden beneath that one event. It's very important for nurse leaders to remember to do complete RCA to find out which process is failing. So this is the WHO surgical safety checklist. I want you to look at this one item here. Has the patient confirmed her identity, site, procedure, and consent? The question is, has the patient? That means the patient must confirm. It has to be done by nurse and anesthetist. And this usually happens at the pre-op area before the patient goes under the anesthesia. Look at the videos also. It is happening in the pre-op area. Nurse, the pre-op nurse and the anesthetist, they come together, ask the patient, sir, can you please state your name, compare the UHID, then ask him what surgery is he going through, has he given the consent, and which side is he getting operated. He's able to show that. After he confirms, then you say whether the surgical site is marked. Then allergy. I'm not going to go through each item because each IPS goal itself is at least 90 to 120 minutes workshop for someone to understand this completely. I'm trying to take you through all of the goals in one go, and I really hope you will take it further and deep dive into each goal to see whether your processes, your protocols are, safe or not. It's very important. I have seen checklists where surgical safety checklists had been modified to fit cesarean. They created one checklist only for cesarean. Make sure that nothing goes wrong because it's a mother and child hospital. I got this as a sample from internet only. So I keep thinking that, people are innovating. They're adding layers of safety to make sure nobody does a mistake by mistake. WHO gives permission to modify the checklist. That time you cannot use the WHO logo, but you can say it is modified from the WHO surgical safety checklist adapted for England and Wales. That is WHO logo is not there. It is possible to be done. So I really hope that it's not worth it. I always say this. If a hospital says that in 10 years, this is the first time we had a wrong surgery. But for that patient, it is 100%. Would I like to be that one patient in 10? Would you like to be that one patient in 10 years to have the wrong surgery done? Answer is always no. Then why do we expect another human being to undergo that? So while we acknowledge that, to err is human, that does not mean that we should do anything less than what is available as evidence that what we need to do for the patient to keep them safe. Goal number 5, reduce the risk of HAIs, HAIs. Hospital acquired infection is a very large domain. Now, I do education program for ICMs. One thing becomes very evident, that our understanding of many protocols are not the optimal. We kind of know many things, but not necessarily we are doing more that we can actually do, because this particular document is talking about hand hygiene. Can you imagine? And if we ask Indian hospitals, what is the hand hygiene compliance? Oh, everybody will have more than 90%. In reality, I can tell you, it is never that. At least I remember one of the students telling me, ma'am, it will be around 40%, but we cannot report 40%. Why? Why are the leaders not allowing the right story to come out? That's my question. We cannot improve if we don't tell the truth, because we are, again, like the cats who drink the milk with their eyes closed and thinking that nobody is watching, they're drinking the milk. Similarly, I close my eyes and say my hand hygiene is 90%. Nothing to do, no? So problems will keep cropping up. Australia as a country for 2023 has kept the benchmark for hand hygiene as 80%. And where are we? So I'm not going to get into it. We all know about hand hygiene, the 5 moments of hand hygiene, which moment is the worst. All these things we know, but question is, what are we doing? And then we say monthly our compliance is 94%, 95%. Someone even mentioned to me the NABH assessor will not accept it. I said, what? Cannot be like that, right? They are looking for improvement. No accreditation body is looking for X percentage of compliance. They are looking for your efforts to make things better and safer. And that is what is accreditation all about. It is not about a particular number. They have to be convinced that you are doing something to improve the safety of the patient, right? So we are aware of all this, reduce the risk. So I would say the starting point is standard precaution. So there are all these elements which are sitting there, which needs to be applied by everyone in the hospital. The top one is, of course, hand hygiene, PPE, staff safety, environmental cleaning is coming out as a very big one. And then we need to focus. It is, nurses cannot say now this is housekeeping responsibility. Patient is our responsibility. So all the equipments, the environment patient stays in, is our responsibility. So I should know what to ask them, what to supervise, what to check. So it is good to be informed about these domains. Clean and reprocess shared patient equipment, single-use equipment, multi-use equipment. How are they being cleaned in between the patients? Hygiene, cough etiquette, using aseptic technique. Very easy to say, we all know aseptic technique. Go a little closer, you might find gaps. Then biomedical waste management. These are the major domains of standard precaution. So every healthcare professional should be trained in that. Hand hygiene is the cornerstone for preventing HAIs. So let me go to the next one. So we finish this standard precaution. So this in the goal 5, there are certain items which needs to be taken care. Hand hygiene always remains on top. Environmental cleaning is coming pretty much on top. Screenings, categorizing and isolating the patients were required. Public health surveillance, because what is happening in the public is also important. And now the focus is on antimicrobial resistance, that is antibiotic stewardship. If you know, in few years' time, we will not have any antibiotic to treat ourselves. Would you like to imagine a world like that when there are no antibiotics that will work? MRSA, which was not heard of long time ago, now it is very common. All resistant organism, multi-drug organism, we are saying it is getting worse. Remember, someday you, me, our relatives will also need antibiotic. God forbid that there is nothing to treat us with. We don't want that to happen. So nurses can also participate in antibiotic stewardship. I cannot teach you right now into that because there is very clear document about the role of nurses in antibiotic stewardship. It is not only the doctors. They do have a major role. Procurement, storage, all will come into that, but there is, yes, and always following the patient safety guidelines. So that is goal number 6. Goal number 5. And goal number 5 is 6. What is goal number 6? Before we get into goal number 6, I will only tell one more thing. In all these patient safety goals, if you have a process of involving the patient and the family, it will automatically become safer. When you don't get compliance for hand hygiene, teach the patient. Tell the patient don't allow anyone to touch you without hand hygiene. Imagine what will happen. Teach the patient that this ID band has your name and UHID number. Before every single medication, before every single procedure, before taking you anywhere, somebody should be asking you your name, matching the details of your name and number with your file. This is for your safety. If we take that pain of educating the patient and the family, don't you think that things are going to be safer? You don't have to monitor much because the patients will be monitoring themselves and monitoring us. Make them partners. Make them partners in the safety journey. And this is what WHO patient safety this year is going to be. Engaging patients and family. That is the focus of patient safety this year. Goal number 6 is reducing the harm secondary to patient fall. Now, all of us know when patient comes to hospital, you have to do a fall assessment. And many of you are doing Morse fall assessment. Anybody doing any other tool? You can put it in the chat box for a minute. Can you give me the tool that you are using, the FRA or the FRAT, they call it, fall risk assessment tool. What is that you are using? So Apollo is using Apollo. Hello, don't confuse. Braden is not for fall. Braden is for pressure injury. Braden is for pressure injury. Fall risk assessment tool. What do you use? John Hopkins. Somebody is using John Hopkins. Pediatric Humpty Dumpty. Okay. So you do have modified modes. Okay. Humpty Dumpty. Harris tool. Okay, this is something. FOT. I don't know what is FOT. Okay. Some are, many of them are heard, some are not heard. So let me just get into the explaining this. So you need to have all risk assessment on admission. I will open the, voice audio once I finish. Josephine, just hold on for 1 second, please. So fall risk assessment at the time of admission. Hey, 1 second. My pen. Oh, just a moment. Let me fix that once again. Okay. Yeah, now it's okay. At the time of admission, every shift and when condition changes, we do have a common problem of copy paste among nurses. Whether it is Braden scale for pressure injury or fall, people tend to write the same numbers when condition changes. Even if the patient today is fall risk free and tomorrow he had surgery, he will become at risk. So it's important to know that whether we are assessing correctly and whether we are implementing fall prevention strategies. Very important to involve patient and family. When I was in the hospital, every single fall that I had witnessed in my hospital, I used to always interview the patient. There is one thing that came to my knowledge whenever I interview. The patient was never told that, sir, ma'am, from our assessment, you are at risk for fall. To prevent that, please follow this. It was never explained. The other problem is the attendants who keep on changing. So usually the patient is maybe little frail, elderly. Sometimes we don't even bother because, oh, he's 60 plus. Okay, maybe better to tell the son or the daughter. It's not like that. If the patient has his faculties in place, we have to educate the patient. This is very, very important. Involve the family. Now, I'm sorry, this is actually should not be here. This is a mistake. That is from the last slide. So please don't bother about that. Involve patient family. That is very, very important. So I'm going to share with you something that I found while I was reading, prepare for this. I'm going to share that with you. So there is this article is from, I think it's from AJN. They talk about the recent meta-analysis where they found adult patients spend 87 to 100% of their time sitting or lying in bed. So the question is, when someone becomes patient, we tend to spend more time in the bed. Is it really required? That's one question. The study of functional impact of 10 days in bed. So that's why once you get into hospital, you become weaker. Why do you become weaker? Because we are no more active. We are asked to stay in bed. No aerobic activity. So they found 12% decline in aerobic capacity, 15.6% decline in knee extensor length. Maybe at home they were walking in the park or doing something. Once we tell them risk at fall, you better stay in the bed. So we are making them even further risk. That means their capacity is getting lesser, their muscle strength is getting lesser. So the question now is, are we focusing on the mobility of those patients who are at risk for fall? There is a complete outlook on the way that fall prevention is done now. The question is to understand what are the factors contributing, not only just doing an assessment of patient using some tool and saying, oh, he's at medium risk or whatever. No. Make it more personalized and see what are the factors which are present in this particular patient, which is going to make them at risk. What factors can be modified? Are there factors that I can modify in this patient? Do we know what are the intrinsic factors that can make this patient susceptible for fall? So there are many things, one 60 years old and another 60-year-old will look very different. I am 64 years old. Imagine your 64-year-old patients who are coming, the female patients. You will find them like me, maybe not. So it's very important to understand the patient. The factors which are putting them at risk, not only the age, there are other factors. What are modifiable? Can I modify them? Do we encourage patients at risk to be immobile or we encourage them to be mobile? That's the question. Most of the time when a patient is at risk for fall, what we do? Put both the side rails up. And if they try to move, we will tie them up, restrain with orders. Without thinking more the science behind it. Is that the right thing to do? So these are questions I'm leaving with you because a complete session on fall, but this is the new thought process. Now, these are new things. I don't know how many of you have heard about it. I'm not sure. But I really liked what I read. So I'm sharing this with you. This is written by Hendrik. So she, who has created the Hendrik 2 fall risk assessment tool. So she has come up with this new article, and it's a very new thought, reimagining injurious falls and safe. So she's talking about ERA. ERA stands for Electronic Health Record Integration. I mean, now with all artificial intelligence and everything coming in, use the electronic health record, it can by itself throw up warnings, especially looking at their diagnosis, looking at their assessment, looking at their drugs, and then telling that this patient is at this risk for fall. Risk factors that matter. Identify the risk factors that matter, not the ones that don't matter. And then assessment and making care plans. So understand what matters, establish historical baseline. This is very important. So there are, in Hendrik risk assessment model, there are 5 intrinsic risk factors. There are 2 classes of medication and 1 simple gait and balance test. This is something that is not available in even the most, this one. Gait and balance test, never done, at least as long as I was in the hospital. So they also talk about 4 M's. I mean, reducing everything that you need to do into 4 M's. Identify what matters. Take care of the mentation. Up here, the faculties up here, how much they understand, how much can they are alert, they know where they are not. Medications and mobility. You can access this. If you write this in the internet, you will find this article, and I am just bringing the essence of it here because I cannot discuss the entire article here. But I thought it's now maybe time for us to reimagine how to prevent falls, not just go by the same thing, same thought process for the last 20 years. We have our basic problems like, patients having pajamas that are longer for them. So the trip on the pajama itself, the side rails which are not locked, they're not working, or the wheels which are not repaired on time. So there are our own problems which are there. Advanced countries, they have their own problem. And yes, we are always looking towards those countries for new evidences because we are not able to come up with our own evidences. So till then, we have to rely on other people's evidences. So I thought this is one Hendrik 2 fall risk assessment, maybe a framework or an assessment tool that one can look at. So the forum framework is actually created with age-friendly health systems. This is with Hendrik involvement. This is, and I thought that all the things what you need to look into is also available under that. Understand what matters for this patient. What are the healthcare outcomes? Medication, what medication patient is getting, how is it going to interfere with the patient's level of consciousness and their level of mobility? Is it going to make them at higher risk? Mentation, prevent, identify, treat, manage dementia, depression. Now this is majorly focusing on elderly patient, but is it possible that your young patients can also fall? Can I have some answers on the chat box? Can young patients also fall, even if they are not high risk? So Melisha told yes, 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 yes. I have enough and more real stories to tell you. That's why postoperative patients, they come into high risk category. I still remember one patient who fell down because of micturition hypotension. Now we need to go and figure out what is micturition hypotension, not hypotension. Very young patient falling down. Now it's very important to know that there are variations by which the patient can fall. In that case, what is that personalization you need to do? Because you don't know who is going to have micturition hypotension. And also we should stop always just saying that side rails is the culprit. When I was working, my supervisors, usually when they report fall, they will say, ma'am, this patient had a fall, but the side rails were up. It sounded as though side rails is the magic wand to prevent all, falls. It is not like that. Side rails is one of them. Grab bars is one of them. One of the common problems that we found in one of the Indian hospitals when we were doing a project was, we have majority female nurses. Female nurses go with patients when they go to toilet, when they are at risk for fall. What will happen? Male patient feels shy and he will tell sister, you wait outside. She will wait outside, patient will fall inside. So we realized that the process was not right. We should actually be sending a male nurse. In Indian culture, male patients, they don't like to have females with them when they're in the toilet. Other very funny thing, the length of the pajama was too long. The chappal that was used was not the right chappal. So these were all modifiable factors to modify just like that. So it is very important not to just simply do what everybody has been doing for years. Go little relevant and practical and try to address the problem to see that what can be. I think what matters is a very important word, I think. If you keep that what matters in your head, then probably you will find out what matters for your patient. That's very important. And any tool that you use, today I will encourage all of you that please, it's not just patient having IVs at risk. No, there are categories of drugs which needs to be assessed whether this patient is on that drug, then the patient is at risk for fall. Because if I take Avil, I'll sleep for 2 days. And in between, if I get up, then I'll be groggy and I'll be going like this. I know that. So it is very important to know that which patient, what medication, what is putting them at risk for fall. So please go ahead, read up what is latest coming up in prevention of falls. Now, I think I finished. Yeah. Now we are coming to goal 7, which is not part of the international patient safety goals, but this is required to be done. Is reduce harm associated with clinical alarms. Now, this is a new domain for many of you maybe, but it has been around at least from 2015, 16. And when I was a critical care nurse, we never called it as reduce harm, but this is what we followed when we were abroad. So when I came to India, we were not able to implement this as long as I was in Fortis. It did not process. Now I think a lot of things are getting protocolized. So what are the segments that we need to take care? There should establish alarm system safety as a hospital priority. That means it needs to be documented. Identify the most important alarm signals to manage based on the following: clinical inputs, risk to patients, alarms needed, published best practices. I would like you to think of one terminology called alarm fatigue. I'm a critical care nurse. When I was working in critical care, when I go to sleep also, I'll be hearing alarms of my papa, poo, poo, all that type. Sound will be coming all the time in my ears. But alarms have got different tone. Huh? One is called an alert tone, another is called advisory, and then there is a sentinel, kind of, there are different tones are there for different machines. When you don't adjust your alarm, what happens? They will alarm unnecessarily. So every time you will say, oh, it is not that alarm. You go and put it off, you go and put it off. After some time, it doesn't matter what happens. You get desensitized. So you don't want that to happen because it can put patients at risk. I remember intensivists used to come and complaining to me, ma'am, do something. Your nurses are putting the ventilator alarm without looking at the alarm. This can happen. So all nurses, students, one basic thing that you can learn today is never put off alarm without understanding what is this alarm. And the second thing you should do is look at the patient. Any alarm, don't spend time looking at the machine. Look at the patient. How is your patient? First, ensure your patient is safe. So ventilator alarm, there is a standard protocol. Don't waste time figuring out what is the alarm. Disconnect, umbu back the patient, then figure out what is the alarm. If you can find out what is the alarm immediately, you can fix it. Otherwise, don't waste time. It's a simple, basic. So when this becomes a patient safety goal, that means it needs to be documented. What alarms and, based on all the inputs, you will say what are the alarms, and also policies and protocol to say that what alarm should be identified and who will be the people who can adjust the alarms or you can change alarms. There is something called personalizing alarms for patients, personalizing. That means you will adjust what is the heart rate for the patient, the minimum and maximum, what is the heart rate to be set for patient B, what should be the saturation, because it will not be same for everyone. So once you personalize the alarm, I still remember when I was a critical care nurse working in Doha, my last assignment as a critical care head nurse, every shift my nurses used to adjust the alarm. They were trained to do that. Based on the patient's vital signs, they will adjust the alarms for the heart rate, saturation, BP, all the whatever alarms could be set, they will personalize it. And sometimes what happens when you are admitting a new patient, there is a process of discharging the old patient completely from the system. If you don't do that, the old alarms will be applied to the new patient. I don't know about the new monitors, how they work. So it is very important to understand your machine also very well so that you know this is how my machine can help me and this is what needs to be done. So educate staff and licensed independent practitioners about the purpose and proper operation of alarm systems for which they are responsible. Many years ago, I approached one medical superintendent. I told that I have a workshop preventing alarm fatigue and improving the alarm safety. She was really excited. She said she would like to have that workshop. Finally, I was not able to do that because it was not seen as a must-have area. So now, please, while you go from here, think of this as your IPSG Goal 7. Though you may not find it when you Google, you will not find this as the Goal 7. But yes, this is Goal 7. And this is required for JCI, which is mandated, I think 2 years ago already. NABH, I'm not very sure whether it is mandated, but it is going to be mandated very soon. So what is required? Clinically appropriate settings for alarm signals. When alarm signals can be disabled, it should be documented. When can you disable it? When can be changed and who can change the alarm parameters? This is very important. It cannot be given to people who are not aware how to do it. So every shift, when we were doing the adjustment, it was validated by the team leader of the ICU. She or he has to go around and check that all alarms set were correct. So everything was very clearly done, but those words were not, I'm talking about 1997, before 1997, long time ago. We were practicing it without these words being in place because we knew that this is a problem, because unnecessarily the whole day the ICU will be the whole day it is, making so much of noise. We wanted to reduce that noise. That's how we went about personalizing the alarms. Then who in the organization has the authority to set alarm parameters to off? There are some smart nurses who understand the system very well. They will put the alarm off. In Hindi, there is a saying, no, na rahegi baas to na bajegi basuri. So they put the alarm off only. So no alarm, no problem. So never ever do that because it is very unsafe for patients. You know what is happening to the patient, right? Checking individual alarm signals for accurate settings, proper operation, and detection. So the monitor's PPM becomes very important, that they are able to give the right alarm at the right time, the right. Okay. Now I was hoping that I should finish at 5 o'clock. Glad that I am able to finish, but the last but not the least, let me tell you, people recognizes this, what I showed here. Anyone recognizes this? What is this? Let me see. Can anyone recognize this photo? Indications are already there. Anyone? Okay, maybe you're all tired this evening. Oh, Crimean War. Okay. So I wish you wrote Crimean War means who? Florence Nightingale. She was the first statistician. She made, this is called the Rose diagram. Today we call it as graph diagram, pie diagram, or whatever. She came up with this data. I put it here to say that for all patient safety goals, please make sure that you monitor and you measure. This is very, very important. Don't think that everything is, happening because you have designed the protocol, you have trained the people. Please remember, you can only manage what you can measure. That's very important. Writing SOPs protocol is only the beginning. Implementation is much more harder. Once training is not good enough. So monitoring, measuring is very important. Don't restrict yourself to the quality indicators which are given by accreditation bodies. You want to make more nursing sensitive quality indicators, make them, measure them, track them, monitor them, use them to make your care safer. Now, just for everyone here, if you want to get a certificate, just give me 1 week. It can only happen 1 week. You need to visit Cygnia Healthcare Academy.com. You can create an account. You will find this recording there. IPSGs Made easy. Watching is optional, but there will be a post test. The question will be from what we have discussed, only from what we have discussed. So if you pass the test with more than 80% marks, you can download your certificate. But after 1 week, today is Friday, so before next Saturday, after Friday next week, you can visit. I will share the link once it is ready, but just for your information. So I'm going to stop share here, and anybody, is Josephine still here or has she left? Somebody wants to speak, you can unmute. I can allow you to unmute. I hope you found this session useful. Yes, you can raise your hands, those who are sitting there. Okay. Thank you so much. I made this 2 hours of session free webinar. It's because I really want patient safety and your safety. Nurses' safety also is very important. So if anyone wants to speak up, please let me know. If anyone wants to speak, just send me a note. I'll be happy. I can stop recording for the time being. I'll just give me a minute. I will not allow everyone to talk.